And good evening, everyone, and welcome to the Oculus Clinical Webinar Series. My name is Dr. Bill Tulo, Chief Medical Officer at Oculus, and I am extremely excited tonight to have our speaker, Dr. George Waring IV. George is going to talk about data-driven decisions, premium IOL planning with the Pentacam AXL WAVE. Dr. George Waring IV is the founder and medical director of Waring Vision Institute in Mount Pleasant, South Carolina. He also serves as adjunct assistant professor of bioengineering at the College of Engineering and Science in Clemson University. Dr. Waring also served as associate professor of ophthalmology and director of refractive surgery at Medical University of South Carolina, Storm Eye Institute. He's a diplomate of the American Board of Ophthalmology and a fellow of the American College of Surgeons. Dr. Waring has received numerous awards and distinctions in ophthalmology, including the Presidential Award and the Distinguished Lands Award, both from the International Society of Refractive Surgery. He's active in clinical research and incorporates the latest advances in technology into his practice. He has performed surgery, taught new surgery procedures, and delivered invited lectures on 4 continents. He participates in and chairs numerous professional committees and sits on the editorial board of both the Journal of Cataract and Refractive Surgery as well as the Journal of Refractive Surgery. Dr. Waring also serves on the executive committee of the International Society of Refractive Surgery. Without any further ado, Dr. George Waring IV, welcome. Thank you.
Well, Bill, thanks so much for the kind introduction and for the opportunity to speak tonight. And we appreciate all of you taking time out of your busy schedule, time with your loved ones, to join us on an educational symposium regarding the Pentacam AXL WAVE, a diagnostic device of which we feel it really sets the standard as an all-in-one solution for the contemporary corneal lens and refractive cataract surgeon. It's really my pleasure to introduce this device. We've had an extraordinary experience with it since the introduction to the United States market. In fact, we've been very fortunate. I believe we had the first device commercially in the United States. And this is an extraordinarily powerful device. You heard me say at the onset, ladies and gentlemen, all-in-one. And what do I mean by all-in-one? The heart of the Pentacam, for those of you that have used the Pentacam, is going to be intuitive to many of you. But this is the most advanced version commercially available, not only for corneal refractive surgeons, but for those of us that are also involved in keratoconus evaluation, phakic IOL planning, refractive cataract surgery, and IOL selection, and patient education, as well as post-op assessment. And we're going to dive into some of these topics today. But what's in a name? Well, many of us are familiar with the Pentacam AXL, which was the introduction of the biometer into the high-resolution Scheimpflug imaging device of the Pentacam. The next generation of this, ladies and gentlemen, was the addition of a wavefront aberrometer, which allows us also not only to measure biometry, but wavefront aberrations. And this is unique in a number of ways, and I'd like to talk to you about just how unique this is and why it's important. First off, this aberrometer measures not only corneal aberrations on the front and back, but also the internal aberrations of the eye, and allows for a total eye aberration profile. This allows one to separate out the origin of the aberrations, whether this is coming from the cornea, the lens, or internally, and then also understand its impact on the total aberrometry profile with the simulated e-target. This is really important because often we may not understand the cause of the visual disturbance, whether that's in the phakic eye when somebody is presenting for refractive surgery or lens or refractive cataract solutions, or in the post-operative state, try to understand where might the cause of dissatisfaction be coming from. So here we see on the left the cornea Zernicke display, in the center the internal visual performance display separating them out, and to the right the total aberrometry display. I'd like to make one other point, and I'd also challenge you all to remember three things from our talk tonight. The first, second, and third thing would be that this is the only device, to the best of my knowledge, that includes both the front surface and the back surface in the aberrometry measurement of the cornea. That is to say that it truly separates the corneal, both surfaces, from the internal aberrometry profile, which, i.e., the lens and other contributing factors. So that's critically important when we're trying to understand, say, the impact of the dysfunctional lens and the different various stages of lens dysfunction, and separating that out from corneal optics. So what are some additional benefits of the Pentacam AXL WAVE? Well, first off, there's no glare before and during the aberrometry measurements, and that allows for a larger pupil diameter. Why is that important, ladies and gentlemen? This is important because the pupil is the gateway to aberrations of the eye. That is to say, aberrations are entirely pupil limited. So the larger surface area we have, the more information we capture, the better understanding we have of the total contribution of aberrations on the eye. The true calculation of the internal wavefront, that's just what I said. This is not including posterior corneal data, so we truly understand the impact of the lens independent of the posterior cornea. Again, a unique feature of this device, which makes it very clinically relevant and useful. The prediction of post-op visual performance using spectacle correction. Now, this is quite interesting in that this device has the ability to capture, because it has an aberrometer, both higher order and lower order aberrations. This allows us also to generate an autorefraction and has the ability to even correct for the lower order aberrations to give some sense of what post-op visual performance would be with the spectacle correction. This has been validated in a number of publications and has been shown to be highly repeatable, and also includes normative data for total eye aberrometry. And this is an ongoing work in process, and our institute is participating in the normative data. Now, many of you that have been habitual users of the Pentacam are used to your profiles that you've set up. But I'd like to introduce to you the new full sequence overview. This is really an updated at-a-glance screen that includes really all the necessary information for the contemporary refractive lens and cataract surgeon. Well, what do I mean by that? Let's dive in here, and we're going to kind of go through that piece by piece. But before we do that, I just want to let's get oriented to what the workflow might look like in our decision making in refractive cataract surgery. And we've got the full sequence overview, of which we just gave you a glimpse of. And this has a number of very, very useful data points. The pupil diameter, both in mesopic and scotopic conditions, the various keratometric values and chords, the different corneal maps that you can customize if you like, and of course the Bellin, Ambrosio, and Final D. Now, so that's where we would start, is with the full sequence overview. That's our workflow. And these are some of the key things that we're looking at. Now, in borderline cases, for example, post-laser vision correction and things of this sort, we're going to also want to look at the back to front ratio. We're going to check to see, does the refraction, axial length, keratometric values, and pachymetry, do they all match and make sense? We can check corneal optical densitometry. And this can be very useful for things like endothelial dystrophy and or other opacifications of the cornea for various reasons. And then one of the tools that we have found absolutely invaluable is the visual performance display in educating our patients. We can also check visual performance using spectacle correction, as we mentioned. But in our clinic, we actually have never employed the use of animated educational video. And there are some outstanding content available and outstanding software. But we feel that taking a patient on a digital tour of their own eye is invaluable. And that's exactly what the Pentacam AXL WAVE allows us to do. Now for IOL selection, of course, we're going to check our low order and high order aberrations, as we mentioned. We're going to understand the impact of corneal spherical aberration. We want to understand which direction it is. Is this positive? Is it negative? We're going to check for other higher order aberrations such as coma and other forms of irregular astigmatism. We're going to check cords to have an understanding of this. We can talk about this a little bit more. And of course, pupil diameters and the various lighting conditions is also can also play into some of our decision making. And then lastly, the AXL of the AXL wave is a biometer. It also measures the axial length, but more importantly, it feeds the Ks and the axial length into the onboard calculator and multiple calculators. So we can open the IOL calculator, we can select the IOL formula of our liking, and this includes both naive and post-refractive calculators. We can select the IOL of our choice, and then of course export and or print the IOL power calculation. So it's extraordinarily powerful, comprehensive, all-in-one device that allows for this type of workflow that we see in our office. Now let's dive in a little bit to this new full sequence overview. And here we have a typical cataract that may present to our office. And this is just gives you a little bit of a sense of how we might evaluate a patient. So first off, we've got this very intuitive toggle switch between both eyes. So at the click of a button, we can toggle between left and right, because what's the first thing that a patient asks you when you show them their eyes? Is this my right eye or my left eye, Dr. Waring? So this gives us a very easy way to toggle between. Then we have the objective refraction. And this is really nice because it also does a refraction based on pupil size as well, which is very unique. And so you can see the effects of myopia in scotopic conditions. We've all heard of night myopia. And then we have just what we need for our keratometry and other corneal properties for our surgical decision and planning with our SIM-Ks, our total corneal refractive power in a 3 millimeter zone for highly aberrated eyes, and other corneal properties too, such as the back to front ratio at a glance, our corneal thickness, and then also the chord mu, of which we named chord mu in 2015 as a physiologically relevant measurement of the optical axes. And we appreciate Oculus including this information in the new full sequence overview. So a lot of interest around centration planning, candidacy for different types of IOLs based on centration parameters, and so this can be useful. A couple other things to point out as well is the anterior chamber depth internally, or otherwise known as the aqueous depth in the bottom right for phakic IOL planning, such as the EVO ICL, and the horizontal white to white, which has been shown by Morgan Micheletti and others to be probably the most accurate form of a white to white in a single device for the Starvision EVO ICL. And then critically important, in fact, one of the first things I look at is the axial length. It's just so useful when I have a post-refractive patient who's now in readers and they want that next thing and they're coming for a custom lens replacement evaluation. At a glance, I can assess their risk of a retinal tear or a retinal detachment, and therefore their candidacy for custom lens replacement or refractive lens exchange with axial lengths 25.5 or greater with a form vitreous base. So these are things that we can look at a glance to help us in our clinical decision making in a data-driven manner. Well, let's look at a clinical example. You just heard me mention the patient who may present for lens replacement. Here, when we look at the at a glance, we can see a few things. First, we can see that the corneal thickness profile is relatively thin. Second, we see a typical myopic pattern in the axial and maps, and we can zoom in on different zonal corneal refractive powers using the total corneal refractive power map as well. And we instantly see a fairly well-defined post-myopic LASIK pattern. And so what else do we see here? Well, when we look at their objective refraction, again, that is already baked into this screen, it doesn't match the axial length, which is high, 26.184. So again, this really confirms what we already know based on this myopic LASIK pattern. But what is more important is not so much to tell you that this is myopic LASIK. What's important is to tell you that this 50-year-old with a form vitreous base may have an additional risk factor for retinal tear, retinal detachment with refractive lens exchange that they're requesting because they feel that they've outgrown their LASIK and they are now in full-time reading glasses. This tells you that they were once a fairly high myope. And so again, this in a data-driven way at a glance helps us understand what the implications may be and what we may or may not recommend at this stage in their life. It also helps us understand other things such as their spherical aberration. Well, this is maybe a moderate size optical zone here and with a fair amount of positive spherical aberration. And at the 6 millimeter zone, this is actually measuring 0.47 microns of spherical aberration positive. So again, this helps us look at this and make some understanding of the candidacy of what kind of lens we would use when the time does come for a lens procedure, such as a highly negative A-sphere IOL. That would be the lens of choice for this profile. Again, a data-driven decision based on the data provided in refractive cataract surgery. And then lastly, if there are questions and perhaps more borderline cases about what type of procedure did they have, then we can reference the back to front ratio. And here we can see that this is a low back to front ratio. Well, here's another example where we have a patient with a visual disturbance, and when we do the full sequence display, what we see at first is that most of these aberrations are arising from the cornea, not the internal lens. And when we then click and look at the corneal optic densitometry map, many of us are used to looking at the lens densitometry map. We've done a number of studies looking at lens densitometry, and part of the some of the foundational work for the dysfunctional lens syndrome and the various stages. We've actually gone on to look at this through through lens densitometry. But what we can see here is that this patient actually has, again, has a LASIK flap that has had some LASIK flap issues. And you can actually identify the periphery of the LASIK flap and the side cut really beautifully here. So we can see this hyperreflectivity in the periphery, respecting even the hinge, where we don't see the hinge in the bottom left superiorly. But then you can also see the densitometry density map, if you will, and we can see some of these subclinical but fibrotic changes around the edge of the LASIK flap, all of which are normal. But it gives us a sense of just how, at a glance, we can also see, yeah, this patient had LASIK as well. All right, so if there was any question about that. Well, where do we go from here? If you reflect on our workflow, we can see that the IOL power calculation is also available to us. This is a long scan, which is very, very short. So this is a separate workflow. It's a separate scan when we do the biometric evaluation, and incredibly efficient, particularly with it being done on a single device. But what we see here is, okay, we now have understand this patient has had myopic LASIK. So this is put into the post-refractive IOL power calculator. We've selected a few of our post-refractive myopic refractive IOL calculators of choice and formulas, such as the Hill-Potvin-Shamus post-myopic LASIK formula, and of course the Barrett-Truquet marked for prior myopic LASIK. And so not only do we have a single output, we have a double output, which can help us to sort of cross-validate these findings. And sure enough, when we look at these, we can see that they actually agree quite nicely. So, and depending on what lens we may select here, then we can almost have a built-in validation with both. So that kind of automatically gives us comfort when we're deciding our intended target. Well, what about when things don't go as planned and we have a patient who's complaining of blurry vision after refractive cataract surgery? Well, this is also has some very useful features as well. Of course, it can check the objective refraction, which is just wonderful. Then automatically we can look at the full sequence overview, where we can, of course, confirm and check our tomography. Remember, this is Scheimpflug elevation-based tomography. And this is also check our keratometry. And then we can check a front image post-op axis. One of the things that I did not get into the details of was the power of the retroillumination image as well on the full sequence overview. This is really useful, ladies and gentlemen. Of course, in the phakic state, showing patients their cortical changes and the different types of their cataract, and also yourself, but also very useful in the postoperative state because it gives us information. It can actually measure the IOL position in terms of rotation or misrotation, malrotation, and decentration. In addition, it has the Barrett RX, which is an extraordinarily powerful tool by Graham Barrett for helping us understand what to do with post IOL refractive surprises, and can help us select the best option, whether to rotate a toric OL if it is would be proven useful, or piggyback an IOL, or to an exchange an IOL. So it's really an all-in-one solution that helps us understand what to do in the rare case of a refractive surprise. Well, here's the post-op axis retroillumination image, and we see a few things that are readily notable. Number one, we can identify the capsular rhexis with sufficient optic capsule overlap, and you're going to hear more and more about that as time goes on. And again, these are some of the concepts that have come out of our work on centration. And Vance Thompson's gone on to publish on some of these ideas for the importance of the capsule optic overlap and why centration matters. And again, a lot of that is based on our original work describing chord mu and the different chords and physiologic relevant optical axes. I think it's the most succinct way to say it. But this also, and it shows the IOL axis. You can see the hash marks on the IOL and the IOL center location as well. And so this is very, very useful at a glance. And we can see, hey, is this patient aligned? Is it not? And when we look at this, here we can see that the IOL axis is measured at 82 degrees, and the center location is 0.24 millimeters, and actually gives us the coordinate at 163.1 degrees. Again, very useful. And we also have the different reference locations as well that we can select or deselect based on some of these physiologic parameters. So again, at a glance, helps us understand centration as well, and as well as rotation. Now, a number of these data points have been validated. Rohit Shetty's group has done most of the original work looking at the repeatability and agreement of wavefront aberrations with the AXL wave, not only in normal eyes, but also in highly aberrated eyes with normal keratoconus and cross-linking groups, as well as the impact of the tear film on the repeatability of these data points as well. So I'd like to summarize with a few points. Remember, my goal when we're have an educational gathering like this is that if you can remember 3 key points, it was worth your time. Point 1, 2, and 3 is this device is an extraordinarily useful all-in-one comprehensive diagnostic tool for the lens, refractive cataract, and of course, corneal refractive surgeon. You heard me mention and emphasize earlier the wave of the AXL wave. AXL is the biometer. The wave is the aberrometer, all in one. What's unique to this device is not only an all-in-one, but it actually measures the front and back surface of the cornea and separates that from the internal optics aberrometry profile, and also summates the two for a whole eye aberrometry profile. To the best of my knowledge, this is the only device that separates out the anterior and posterior corneal surface aberrations from the internal optics. Most devices include the posterior cornea in the internal optics, so that when we're making decisions about where's the issue, is this a cornea issue or a lens issue, this is the most accurate device to do that with. And the AXL wave has been validated in normal and highly aberrated eyes, as you've also seen. It's an incredibly functional and useful device where we've really enjoyed ours. And Oculus never quits. It's just extraordinary when I think about the journey that we've been on over at least 5 to 6 different generations of the Pentacam. And we're working with Oculus on the next one, which we're really excited about too. That is not going to be soon, but it is very, very exciting what they have in the pipeline as well. Oculus has really done our profession a service with this diagnostic device, and I'm just thrilled to be able to go through some of the highlights with you tonight on kind of some of the data-driven decision-making in corneal lens refractive cataract surgery, and how it may relate to different types of IOLs. This is what I'd like to do is to conclude our didactic portion of this, and then see if you have questions that we may be able to address in more of an open format manner. So with that, I'd like to thank you all for your time and your attention as well. Taking your valuable time from your family and after a long day at work to be with us. And I hope that that you can take away 3 points of learning from this session. Thanks very much.
Well, thank you so much, George. Great information. And we do have a bunch of questions. Some of them do overlap, so I'm going to try to condense them together since a lot of great topics here. Let's start out with, you talked about the use of the total corneal refractive power. Could you go into a little bit more detail on, specifically on toric IOLs, when you're deciding between a toric and a spherical IOL, or deciding between what axis and what power you would choose? How do you use the TCRP, or the total corneal refractive power?
That's a great question. And there's a lot to unpack in that question. I think if we back up to the regular keratometric values, I think what's probably more important is the understanding of the impact of the posterior cornea as it relates to with the rule and against the rule astigmatism. And that's why the consolidation of both the front and back surface in the aberrometry profile is so critically important. In fact, aberrometry is probably one of the best ways to understand the impact of the posterior cornea on total corneal refractive power. And so this is, I think in layman's terms, when we look at the impact of the total corneal power, if we have somebody with an anterior astigmatism against the rule of 0.6 diopters or more, we're going to choose a toric IOL usually. Essentially, we will, if we have somebody with a with rule astigmatism in the anterior cornea of 1.6 diopters or more, we're going to choose a toric IOL. So it's around 0.6 against 1.6 width in a normal cornea. And that's the anterior contribution. Now, just to let you scratch your head a little bit, when we start looking at the impact of the posterior cornea with somebody with 0 anterior corneal astigmatism, that is, there's no contribution from the anterior cornea, it's a spherical anterior cornea, that's going to unmask the with the rule posterior cornea, which is a negative lens, contributing to total corneal refractive power that is against the rule. So we are routinely treating zero astigmatism on the anterior corneal surface with perhaps an LRI at 180 degrees and a on-axis incision, which would be a temporal incision, to account for the posterior cornea. So we've just learned so much about this. Now, this can get into a very, very deep dive when we start looking at the holiday reports and the total corneal refractive power in the zonal reports. When we start looking at the contribution in highly aberrated eyes, patients with high degrees of coma, or asymmetric bow ties, for example, that's where we may look at the total corneal refractive power in a particular zone, such as the 3 millimeter zone, for example. So, and again, and if we want to look at that more closely at different zones, then we may look at the holiday report, and which is another drop-down menu to understand the refractive power in some of these different zones. And we may have some sense of the pupil size and perhaps scotopic conditions, and we may try to understand that. But generally speaking, what I may look at is it provides the pupil outline, and I may just kind of get a sense of what some of the keratometric values are showing me in terms of the symmetry within what I may call the effective optical zone, represented in the by the pupil on the various maps. So that's a fairly sophisticated question, but I think probably the most important piece of information to understand, and what would be benefit 99% of your patients, would be just the contribution of the posterior cornea and how we're accounting for that, much more so than some of the various zones, for example.
So before we leave the topic of total corneal refractive power, just a true or false, you agree with this statement, and I'm putting this together from various questions. Um, Obviously, it is not desired to flip someone's axis. If someone starts out with the rule, making them against the rule is not a good thing. So we want to avoid that. Do you find that knowing and understanding the back of the cornea power helps reduce the risk of flipping axes?
Yes. Yeah, I actually think it's much more than that. Um, if we're not understanding and evaluating and treating the posterior cornea, you can't accurately treat astigmatism. So it's much more than just flipping the axis. It's actually being able to treat astigmatism in a comprehensive way. So the kind of the pearl from most will say that the goal is to try to end up with about a quarter diopter of with the rule astigmatism. Um, so flipping from against to with essentially is the goal. And I think another way of looking at it is that it's also what many don't understand is that maybe um, um, I think a better way to think about it is the example I used of somebody with zero anterior corneal
So,
astigmatism contribution, and then that unmasks the impact of the posterior cornea and still treating the posterior cornea. I think that's probably the more pure way to understand it.
so the next group of questions that are asking you about your personal cutoffs, and do you have any personal cutoffs in regards to total corneal high order aberrations or specifically spherical aberration. When you look at those numbers, are there any numbers that will make you change your plan or alter your planning for the surgery?
Yes, I don't. We tend to. It's an important question, and we don't really practice with cutoffs per se because these are multivariate decisions. So we may be looking at 4 to 6 different variables when deciding optically what's the most appropriate lens for a patient. So, for example, we don't ascribe to the idea of certain chord mu values excluding patients from diffractive IOLs. Likewise, we don't have specific cutoffs for higher order aberrations in terms of a raw value for who's a candidate for which type of lens. Instead, we're taking that information, all important information, but we're also looking at the profile of the tomography as well, because often the profile will also give you that information. It's interesting when we understand, for example, if we go to say the case of post-myopic LASIK here, well, we know that this patient's going to have positive spherical aberration without just because the full sequence overview is laid out so beautifully. But then we can quantify it, and lo and behold, that we can see that this patient has 0.41 microns of spherical aberration, positive spherical aberration. So that means they've got a lot. So I know for sure I'm going to want a negative A-sphere IOL, and I'm going to want the highest negative A-sphere IOL. I know for sure I'm not going to want a positive A-sphere IOL. I know for sure I'm not going to want a relatively neutral A-sphere IOL. I'm not going to want a spherical IOL. I'm going to want to therapeutically treat this positive spherical aberration. So it's not an absolute value, ladies and gentlemen. It's really more of a direction. Now, at what point might I switch and flip my thinking? Let's use a hyperprolate cornea, somebody who had previous hyperopic LASIK, and somebody who had hyperopic LASIK for monovision back in the day. We don't do a whole lot of that anymore with modern day lens replacement. Now we have the opposite therapeutic obligation to treat their negative spherical aberration burden, not because of a specific number. If I can see the hyperprolate cornea on the axial map, I know that patient's going to benefit from an IOL with positive spherical aberration, of which really there's only one commercially available in the US with a Rayner EMV, for example. So again, it was not a specific number. Now let's say I look at it and I can't really tell, did they even have LASIK or not? Well, they did by history, and maybe they had a little bit on there. Then, it's a little less crucial. And then we can actually look, and you might see a 0.07 RMS. Then it really is much less clinically relevant. And so that's where that might come into play. I will tell you that the all modern day presbyopia correcting IOLs are based on some sort of negative A-sphere platform. And so many of these, which now have tolerance to refractive error, both for higher order and low order aberrations, can still be used in a case like this post-myopic LASIK patient. But I would not use those lenses personally in somebody with post-hyperopic LASIK, where we are compounding the negative A sphere of the cornea with the negative A sphere of the IOL.
Those low refractive cases, especially when you have no historical information, can be really challenging. When you're faced with that and you can't tell if it was myopic or hyperopic LASIK because maybe it was only a diopter and a half of treatment, would you err on the side of taking the higher plus calculation and leaving them slightly myopic in the worst case? If let's say your calculation was with the myopic formula, I don't know, a 22 lens, and then with the hyperopic formula, 21 lens, would you purposely take the higher plus lens typically, or how do you approach those cases?
Well, they can be very subtle, even for the trained practitioner, every once in a while. And I'll tell you what I find very, very useful, unless there's been multiple procedures, and you have to be careful. But without a clear history of somebody had 5 corneal procedures, and it was just a subtle treatment, and you're not really sure what it was, the holiday panel which is actually also includes a lot of the more detailed cord mu data points and vector analysis, is very useful because it actually provides an estimated refractive change of the prior refractive surgery as well as the direction. And that's really our first thing that we may look at when in question. We've taught our IOL technicians to look at this and incorporate this as well when in question. And so it's a top right panel of one of the two holiday screens that shows the estimated refractive change from surgery with a plus or a minus. So if it's plus, it shows that it had a slight plus. If it was minus, it showed a slight myopic ablation. Bill, to your point, if you really don't know, then yeah, you'd be better off erring myopic, but it really kind of depends on the patient, the lens, the profile, and that sort of thing. So, um, uh, and there are other clues that you can look at as well. Of course, the corneal thickness profile, and then of course compare the other eye and things like that. So there are other little clues. Real importantly is the axial length. We've talked a lot about that today, but that can give you some clues as well. So there's sort of a methodical approach to those more subtle cases, but I love that feature of the Pentacam AXL WAVE with the estimated refractive change.
I have a question I think that I'm going to answer for the audience, and the question is the wavefront data derived from tertiary aberrometry or some other direct measurement, or is it a calculated metric based on corneal shape and axial length? In the AXL wave Pentacam, the calculation is done by ray tracing, and it's done with a Shack-Hartman uh, sensor. So it's not tertiary and it's not calculated. It's actually directly measured via ray tracing and the Hartmann-Shack aberrometry. All right, let me see what else we have here. So you actually, another question, actually two people came in with this question about cord mu and cord alpha. Do you favor one over the other, and are you using them at all when you decide whether or not you're going to use a multifocal IOL, or how do you utilize those two metrics?
Well, we're a little bit biased because I named cord mu. The brief background on that is when we were studying centration and understanding the impact of centration on corneal refractive and lens refractive procedures, we changed the terminology from angle. These were not angles; they were displacement chords, meaning a line with a vector analysis. And then we just went down the Greek alphabet. Myself and Daniel Chang published on this in 2015 in American Journal of Ophthalmology. And when we proposed the term cord mu, but the next available Greek letter was mu. So nothing too fancy there. But the whole point of it was that it was a physiologic way to represent and measure optical centration and optical devices. The legacy terminology, including chord alpha, um, is based essentially on mathematics that are a couple, 100 years old, with Snell's and early descriptions of nodal points and Helmholtz uh, theorems. So not only that, but then you take that a step further, and these were rough mathematical representations that are not physiologic. So we employed the concepts around ray tracing and proposed these terminologies. So we don't really feel like there's any role for chord alpha, and that's why we use chord mu. Now, the other question is, do I look at it? Well, it is kind of interesting. Centration matters. It matters more in the cornea than it does in the lens, but it does matter. If you have a decentered IOL, that leads to coma, and that kind of makes sense, right? Sort of decentered spherical aberration is coma, and that any aberration is going to have a higher impact on a more advanced optical design, such as a diffractive IOL. So we do believe that centration matters. And it gets kind of complicated because the high degrees of chord mu are physiologic. Short eyes are where you'll typically see this because the fovea is swung out more temporally in a shorter eye, and that's why you get these pseudo XTs. Because if you ray trace coaxial beam of light to the foveal center, that does not fall coincident with the center of the entrance pupil, and that leads to these higher degrees of chord mu. So then the question becomes, well, where do you position the lens? So some of these are early descriptions based on this work where you centrated on the subject fixated coaxially sided corneal light reflex, and that was the title of our paper in the AJO. But there is a limit to that in higher degrees of chord mu. If you were to do that, you will start to decenter the diffractive zones sort of beyond to a mismatch of the pupil. And in many cases, that's, believe it or not, okay to a degree, but you can go too far, in which case we propose sort of a 1/3, 2/3 rule with your Purkinje. So this gets a little complicated, but we have taught lots of courses on this over the years and have published on it. So, so does it matter? Yeah, we do think it matters. Do we disqualify patients because of large degrees of chord mu from presbyopia correcting IOLs? The answer is no. But I think the more pure example would be that of a small aperture IOL, such as the IC8, where centration is critically important. And a decentered IC8 does not work well. And so patients will have dysphotopsia, negative dysphotopsia and shadowing. And we've recentered IC8s based on these principles. So some lenses are more forgiving, some lenses are less forgiving, and but we don't really use it as a disqualification measure. But we do use it for our planning. But most importantly, we'll use our original concepts from the intraoperative centration with the coaxial light sources from the microscope for most cases.
So, George, I think we've learned that from our early experience with hyperopic LASIK back in the early 2000s, where we'd have large angle cappers and chord mus, and patients wouldn't do well when we centered it on the visual axis. So I think the same thing applies here. And then we started splitting the difference, and we got much better results. But then when we went the full distance, there are times where we get worse results. So it is a very complex, even when it's on the cornea or in the lens, it becomes a complex issue. Um, Oculus will be providing in the near future, by the end of the year, hopefully, some normative values for and also associated with different IOL types, EDOF IOLs and diffractive IOLs. So that data will probably help also determine should you switch from one type of IOL to another. So I'm looking forward to that in a future release of the Pentacam. So I want to thank you so much for sharing your wisdom tonight. These were great, great tips. I think I've got more than three, but if three is the cutoff, I'm still happy with three. And I want to thank everybody for joining tonight. Just as an update, if you would like a recording of this, in about a week, we render the recording. We'll send it out to all registered guests. And again, one more big thank you to Dr. George Waring for tonight's presentation. And have a great night, everybody.
Thanks, everybody. Thanks so much for your time, your attention. Bill, as a gracious host, and the whole Oculus team for making this possible for all of us. Thanks so much.
Good night, everybody.
Good night.